Susan Bauman, who is a very distinguished professor at the university, at the Michigan State University. She has enjoyed an illustrious career spanning over 40 years, devoted to teaching and research. And her research passion is in the area of neural control of the cardiovascular system and the role of the sympathetic nerve activity. Her excellent work did not go unnoticed, as she had won several awards that included the APS Bodil M. Schmidt-Nielsen Distinguished Mentor and Scientist Award, the Carl Ludwig Distinguished Lecture Award, and the William J. Beale Outstanding Faculty Award from the Michigan State University itself. Quite an honor. Besides, she is also a fellow of the American Physiological Society and has served as its 85th president. And finally, but not least, she is also a co-author of the Gundam's Review of Medical Physiology, of the Medical Physiology textbook. And as we know, this is a textbook that all knowing physiologists are very familiar with, and we use this quite a lot. Right? So this morning then, Prof. Susan Bauman will give a talk on chronic pain, the physiological basis, and therapeutic approaches. Okay, so over to you, Prof. Bauman.
Thank you very much for that very kind introduction. And I look forward to speaking with all of you about a topic that I really enjoy lecturing on, even though I've never done research on pain. I think it's a very fascinating topic to talk about the physiology and pharmacology of chronic pain. And so I'm going to, here's a brief outline of the topics that I'm going to cover. To begin with, I'm going to go through some statistics about chronic pain, and I'm going to provide some information specifically about chronic pain in Malaysia. And I'm going to discuss something that sort of fascinates me of thinking about, is pain a disease or just a symptom of a disease? And then go through some very basic definitions and basic concepts about pain, go through the components of central pain sensory pathways, and then talk about the physiology of three types of pain: nociceptive, inflammatory, and chronic pain, and the neural pathways that modulate pain. I think we have a phenomenal nervous system that actually helps reduce pain by actions going on in the nervous system. And then I'm going to talk about some of the pharmacological treatments for pain. So to begin with, then, those statistics. So worldwide, there are 770 million people who are affected by chronic pain. But in this information that I read, the prevalence of chronic persistent pain in Malaysia is only about 7%, and is highest in, not surprisingly, it's higher in older age groups. And that's pretty much worldwide, that it's higher in older age groups. But the Malaysian population of only having 7% expressing chronic persistent pain is considerably lower than a lot of other countries. The higher prevalence of chronic pain in adult women versus adult men, and that's a worldwide prevalence, and it's more common in women than men. About 85% of patients who experience chronic pain also experience depression. So it's kind of an interesting link between pain and depression. And about 25% of patients with chronic pain experience a sleep disorder. So it's probably not surprising that if you think about somebody who's in pain, that they might have difficulty sleeping as well. But there's a lot of things that occur when somebody experiences pain. It isn't just that you're experiencing pain, it's going to affect a lot of your lifestyle as well. And we'll talk about some of that as we go through this. So There was a report that provided some data on pain that was based on responses of Malaysian individuals who were part of a global study called the Global Pain Index in 2020. And 85% of the Malaysian respondents said they experienced some form of pain in the last year. But again, only about 7% were chronic pain. So not surprisingly, most of us at some point in our day will say we have some experience with pain. In fact, the types of pain are things like headache, tension headaches, muscle aches, menstrual pain, and joint pain. So these are just the top 5 types of pain that they indicated that they experienced in the last year. Only about 38% of the respondents actually tried to sought treatment for their pain immediately. Most of them waited hours to weeks before they would ask for treatment. And in fact, a small percent of people actually never even bothered to treat their pain. About 50% of people take some kind of a medication. This is 48% of people in Malaysia versus 65% globally. So you can see the Malaysians are more resistant, more capable of tolerating the pain and not needing to take some drug to treat the pain. A lot of Malaysians prefer to rest or sleep to deal with pain. And 31% never take pain meds out of fear of developing dependence or adverse reaction. So this is particularly, I know a lot of people fear if they take a narcotic agent, like an opioid, that I'm worried that they might become dependent on it. And so they try not to take it, and they'd rather just work by using non-pharmacological therapies to reduce their pain. But not surprisingly, majority of people who experience pain say that it does have some effect on their quality of their life. And so this is just demonstrated in this chart here. So the variations in color. So the off to the left are indications of very minor of either no problem with life with these various experiences, mobility, self-care, general activity, discomfort, anxiety, and depression. But you can see there's a fair number of people, for example, around 30% of the people here say that they experience this depression. Quite a few people have mobility issues, and certainly a lot of people do experience some problem because of pain and discomfort. And so I found some information about the use of opioids in Malaysia. And again, this is based on a study the study took about a 10-year data, and from 2005 to 2014. So it might be outdated to what's going on now, but it was the most recent that I could find. But they did an analysis of the use of 5 strong opioids: morphine, oxycodone, fentanyl, pethidine, and methadone. And they compared it in Malaysia, Singapore, Indonesia, Thailand, and Vietnam. And they calculate these things based on a daily dose per 1,000 inhabitants. And so they call it the DDD per 1,000 inhabitants per day. And among the countries, Malaysia had the highest total strong opioid consumption. All countries showed increase over the last 10 years, with Malaysia experiencing a 990% increase, and compared to Thailand, only experienced 100% increase over 10 years. But all countries experienced a higher use of opioids between 2005 and 2014. Fentanyl was the most common drug used in Malaysia, followed by morphine, pethidine, oxycodone during that 10-year study. Now, the idea of, pain is, you can have pain because you got an injury, but there's a lot of diseases or disorders that report pain as a common symptom. And this slide shows a lot of the different types of diseases or disorders that people say that they experience pain. And so, not surprisingly, so kidney stones, gallstones, very bad pain. I had kidney stones, and I know those hurt really bad. And but a lot of these things, so there are issues that people report as as a disease that is linked to the experience of pain as well. Now, what are the risk factors for developing chronic pain? Well, it includes biological, psychological, and lifestyle influences that impact your ability to experience pain. And so the biological ones include things like advanced age. That's why I said there's more likelihood of experiencing chronic pain in the elderly than in the younger population. And race and gender. There are more women that experience chronic pain than men. But also even things like obesity contribute to pain. And then psychological issues. And I, again, point out that depression, there's a link between depression and pain. And you can say, well, if you're in pain, you might feel depressed because you know life is terrible because you're in pain. But what's interesting is there are people, it's not in the direction of starting out with having a lot of pain and then becoming depressed, but rather people that are depressed end up experiencing chronic pain for some reason. And so it's a fascinating topic that I teach a class on neurobiology disease, and I have the students read an article about the link between depression and pain. It's quite fascinating. And obviously lifestyle can impact your ability to experience chronic pain. And now I'm going to talk about, is pain a disease or just a symptom of a disease? So we define a disease in general by some objective terms, or we know the cause. So we know that, for example, a reduction in dopamine transmitter release contributes to Parkinson's disease. And so we have an association between some biological change and a disease process. Or there's a specific set of symptoms that they have and signs and symptoms. So you can sort of look at somebody and say, well, by watch the way they walk or move their hands and stuff, you might say, well, they might have Parkinson's disease. Then there's the idea of a symptom is more of a subjective experience. And we think about pain a lot of times as a symptom of something else. And so we talk about it in a subjective experience. There is actually no medical tests for determining the type or severity of pain. Well, how do we rely on defining the magnitude of a pain? We actually ask a physician would ask a patient, how do you feel on a scale of 0 to 10? How much pain are you experiencing? And so this becomes a very common way. So it's up to the individual to tell the clinician how bad their pain is, as opposed to having a test to say you have this level of a disease process going on or a malfunction going on like this. And the important thing to think about is how person A might say this amount of pain, oh, it's a 5. And someone else, that same degree of pain, that same actual stimulus, may actually say, oh, it's an 8. Or another one might say it's a 2. So we can experience it because it's very subjective. And I don't know what a 10 is. I'm not sure that anyone would know what is the worst pain possible. We might all think that anything is the worst pain possible. But so it's all very subjective. And so another way, though, of assessing it is to ask the individual. So a clinician can when they meet with a patient who's coming in because they're in pain, they'll ask them how it affects the quality of their life. And so if the quality of their life is on a scale of 0 to 10, and 0 would be the total lack of quality in their life, they feel hopeless, they stay in bed all day. Or a 3, so you're able to get around, but it's minimal activity and you stay home. Or then a 5, where you can actually go outside a couple times a week. Or in 7, so you have a better quality of life, you can actually work for a few hours each day. Or 10, where actually you can carry on your normal social life and work life. And so again, this is a way that we're defining pain, but again, it's asking the patient to define the pain that they have. So and related to this question of, is pain a disease or merely a symptom? Can pain be a disease if it is often caused by forces from outside the body. You fall down, you're in an automobile crash, you were stabbed. So something is given to you, inflicted upon you, and so that's why you're experiencing pain. But there's a lot of neuroscience evidence that pain is a very, very complicated process. And so regardless of what initiates that pain, whether it be some trauma like an automobile crash, or whether it's a neurological disorder, actual nerve damage, if the pain signal persists, there are changes that occur in both the central and peripheral nervous system. They're really defined. They can actually be, these changes can actually be measured. And we're going to talk about how some of those changes occur in the course of this presentation. And over time, if these changes can actually become irreversible. So pain then is not merely a symptom of a disease. The process actually causes changes in the nervous system that then mean that it's more than just a symptom of a disease. And in fact, the World Health Organization did make a statement back in, I think it was 2007. They came up with a statement that chronic pain should be accepted as a condition in its own right, and highlights the burden of chronic pain on individuals. So this is good. So it really shouldn't just be considered a symptom, but it is actually a disease process in itself when we talk about chronic pain. So now we're going to go through some very basic definitions and basic concepts about pain. Pain is defined very specifically by the International Association for the Study of Pain. They define it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So that's recognized worldwide as the definition of pain. Now, the concept of nociception is how the central nervous system receives signals from pain receptors in response to that tissue damage or threat of tissue damage. And then two important terms, allodynia. This is pain resulting from a stimulus that is normally would not cause pain. So an innocuous stimulus that under certain circumstances induces a sensation of pain. And we'll talk more about that as we go on through this lecture. And then the term hyperalgesia. So this is an exaggerated response to a noxious stimulus. So where under condition A, you feel this magnitude of pain by this stimulus, under another circumstances, the identical stimulation would induce greater pain. So hyperalgesia. Allodynia and hyperalgesia are big contributors to the idea of chronic pain. So let's talk about those nociceptors. So these are the receptors that provide information about the tissue damage or threat of tissue damage. And these receptors are located on the nerve endings of the unmyelinated C fibers or the very lightly myelinated A delta fibers. And these neurons have their cell bodies in the dorsal root ganglia, and then they terminate in the dorsal horn of the spinal cord. So a lot of receptors have structures, like a Pacinian corpuscle has a very specific structure. In the case of pain receptors, the receptors are actually located on the nerves themselves, on those free nerve endings, and C fibers being unmyelinated, and even the nerve terminals of the A delta fibers are unmyelinated. So these receptors located on the nerve endings are very available for stimulation of various types of stimuli that induce pain. And so we'll talk about those too. The transmitters released by those sensory afferents mediating pain, both A delta and C fibers release glutamate, onto the dorsal horn neurons, and they induce an excitatory postsynaptic potential in that dorsal horn neurons that begins the whole process of the sensation of pain. And then the C fibers, so those unmyelinated fibers, also release substance P and calcitonin gene-related peptide. And these are very big contributors to the fact that the sensation of pain. And they're also released in the periphery. So as opposed to just being at the nerve terminal in the central nervous system, when the fibers are activated, they're actually released off in the periphery as well. And so, and we're going to talk about some of those changes that occur due to changes in the changes in chemical nature of the tissue in the site of stimulation, of how that contributes to pain itself. Now, pain is not a stereotype response, and how an individual will respond to a noxious stimulus and then how the pain is sensed. There's a lot of factors that contribute to that actual pain sensation. There are psychological factors that include cultural differences, a history of pain experience. Of, you remember that you experienced something before, and then this is going to affect how you experience that same sensation at a later time. Things like age, gender, and current situation are all going to be part of how you actually respond to a stimulus, and the emotional factors. An expectation of pain can actually make the pain worse than it actually is, or the fear of pain. You might predict that it's going to be worse than it really is, and so when something happens, it actually feels worse than it really should be. Now, there's one part of the pain system, the pain induction of pain, that is very much a stereotypical response, and that is the withdrawal reflex. We've all experienced this. So when you stimulate, you get a noxious stimulus. So this picture here shows stepping on a nail, and oh, that really hurts. That activates the pain pathway going into the spinal cord, releases the glutamate and the substance P and the dorsal horn neurons, and then activates a bunch of neurons in the spinal cord. And what happens is you have this ipsilateral flexor muscle contraction and ipsilateral extensor muscle relaxation, and the limb withdraws from the stimulus. So you deliberately remove your foot from the nail, you move it away from where that nail was spontaneously. This doesn't need the brain. This is purely a spinal reflex. And of course, it's actually oftentimes it's more than just the limb that was stimulated. So not only do you move your foot, but you might move your whole body. Or if you touch a hot stove, you move your whole body away from the stove. This is all, doesn't require a brain for these things to happen. This is purely a spinal automatic reflex that occurs in response to sensation of pain, to the noxious stimulus. And so now we're going to go through those central pain pathways. So how does the information go from that peripheral site of where the nociceptor fiber was activated to where it gets into where we experience pain, the sensation of pain? So it's a very relatively simple process. So the fibers come into the dorsal horn of the spinal cord. They activate a group of neurons in the dorsal horn who has very long axons that project all the way up to the thalamus. So, and it's but notice that it crosses the midline of the spinal cord very close to where the afferent came in, that spinal thalamic tract neuron. So the neuron that starts out in the spinal cord and goes up to the thalamus, that nerve crosses the spinal cord on its way up to the thalamus. And then from the thalamus, from the ventral posterior lateral nucleus of the thalamus, then from that point, it goes on to the cortex. And the part of the cortex that it goes to would be the part that represents the area that was stimulated. So a toe is going to go to the part of the cortex. If you activated the toe, it's going to go to the part of the cortex that controls the toe. And we're going to show that in just a moment. But the fact that it crosses over the spinal cord very close to where the afferent comes in. So if you had a spinal cord injury, you lose the sensation of pain on the contralateral side of the body, whereas you would lose control of your motor function from the ipsilateral side of the spinal cord if you had a spinal cord injury. And also your sensation for simple things like proprioception, those are from the same side of the spinal cord that was injured. But the pain you would have, so if you had a left spinal cord injury, and it lost the ability to transfer the information to the brain. If it was a left spinal cord injury, you wouldn't be able to mediate pain from the right side of the body. And so this is the representation, the homunculus, the representation of the sensory nervous system, the somatosensory cortex. And you can see large portions of the somatosensory cortex for your hands and fingers and your face, whereas your whole leg and everything even has less of a representation than just the fingers. So it's the idea of, you think about it, how sensitive your fingers are to simple touches and injury. You get a little paper cut on your finger and oh my God, it hurts, because you have a lot of representation in the brain for where that finger is being, the information about the finger is carried to. And now we're going to talk about the three types of pain: nociceptive, inflammatory, and chronic pain. So people define pain in many different ways, of many different categories of pain, but I like to describe these three types: nociceptive, inflammatory, and chronic pain, because I think it really helps us to understand how a simple sensory activation over time can lead to actually a chronic pain phenomenon. And so to begin with, that nociceptive pain, so it's going to be nociceptive pain, inflammatory pain, and neuropathic pain. So the nociceptive pain, this is what's associated with simple activation of a peripheral nociceptor. So you can have a mechanical noxious stimulus, chemical stimuli, thermal stimuli. Activating these receptors, you experience pain. And it's an acute pain. This is going to come and go with the process of the stimulation. So you cut your finger, and over time it's going to get better. Inflammatory pain is in response to the tissue damage that was caused, that whatever it was that then caused this injury. Then there's a lot of immune cells that accumulate in that area. And we're going to see how the nerve endings in that area then become exaggerated activity. I like to think about inflammatory pain as sort of the link between acute pain and chronic pain. So this is something that's sort of an intermediate type of pain, It over the time, it'll lead to a chronic pain. And then the term neuropathic pain is very specifically is the type of pain that is associated with damage to either the central or peripheral nervous system. And this for sure is a large contributing factor to chronic and pathological pain. So now we're going to go into more information about each of these types of pain, a little bit more detail about each of them. So to begin with, the nociceptive pain. So this picture here shows a nerve ending, a sensory nerve ending, a nociceptive nerve ending, and these nerve endings have different types of receptors that respond to particular types of stimuli. So chemical stimuli activate things like acid sensing ion channels, or several types of purinergic receptors, or bradykinin receptors. They're actually receptors on these nociceptive nerve endings that respond to these various types of chemicals. And then activation of those will lead to events that will then lead to an action potential being carried into the nervous system. Mechanical stimuli that cause nociceptive pain. also cause an increase in sodium and calcium influx. And thermal stimuli, these the TRPV1 receptors or TRPV2 receptors, these are activated by intense heat. And all of these different types of stimuli, so chemical, mechanical, and thermal, all lead to this increase in sodium and calcium influx, then a generator potential, membrane depolarization, reaching the voltage gated sodium channel threshold, and then an action potential ensues. And in the case of nociceptive pain, this is pain that lasts for only a few minutes or to a few days. It's the kind of pain that leads to that withdrawal reflex when the pain is initiated. And actually, nociceptive pain serves a protective mechanism. So if you injure yourself, then the nociceptive pain sort of prevents you from using that. If you hurt your finger, you might sort of be tender. You'll be very careful of not to continue to abuse that finger, so to speak. So it's protective. You prevent further damage by sensing this pain. It prevents you from further use of that injured area. And then this idea of this inflammatory pain. So I like this picture. It shows a whole bunch of, so in response to tissue injury, so tissue damage stimuli, you get a tissue injury, and this whole cascade of chemicals are released in response to that tissue damage. And so I've highlighted some. So you've got increased potassium and hydrogen ions. You've got bradykinin is released, actually. You've even got serotonin being released and prostaglandins. And these various chemicals end up going and altering the activity of that nociceptive nerve ending. And so they're going to see that all of these end up being excitatory to that nerve ending. And so what happens is here you got the stimulus and you get more and more action potentials. This is a concept that is called sensitization. So this is an example of sensitization in the peripheral nervous system. We're also going to see it in the central nervous system. But this concept of peripheral sensitization is really a big factor in why we experience chronic pain. So peripheral sensitization is defined as a reduction in the threshold and an amplification of the responsiveness in a nociceptive in the nociceptors. So you're going to get this exaggerated response. And so an example of this is the thermal receptors, the TRPV1 receptors that respond to heat, high heat. Normally, a TRPV receptor is activated if the heat is 42 degrees centigrade. In response to tissue injury, those TRPV1 receptors will now become activated even at 38 degrees centigrade. So they become much more sensitive. So you're going to have an exaggerated response. That's that hyperalgesia. And in fact, you can actually get a sensation of pain from a stimulus that is normally innocuous. And I always like to use as the example here, if your skin gets sunburned and you take a hot shower, normally that same temperature shower would be very comfortable to you. But when your skin is damaged by the sun, that temperature that is your normal temperature for taking a shower, it now creates pain on your skin because of these changes, because of these tissue injury, all these chemicals being released, and those nerve endings are more likely to be activated. And then this concept of neuropathic pain, and this is certainly chronic pain. And this is if there's damage to the peripheral nerve or damage within the central nervous system. And this idea of hyperalgesia and allodynia are very common in response to these nerve damages. And neuropathic pain is often refractory to anti-inflammatory drugs and even opioids. And some examples of nerve damage that causes chronic pain are carpal tunnel syndrome, cancer, diabetic neuropathy, toxins, causalgia, trigeminal neuralgia, shingles, and then phantom limb pain. So this memory of pain. So someone has their leg amputated and they still talk about pain in their leg, even though they don't have a leg. And so we always think about phantom limb pain as the example, but actually it can occur. You can have a tooth pulled and you still say, oh, I still have a toothache, even though there's not a tooth there. There's no reason for you to feel pain, but you actually still experience pain. This idea of changes, and this is all because of changes in neural connections in the brain, fibers that were originally coming from that limb. They're now connected to neurons in other areas, and you experience this idea that you've got pain. So back again to this idea of pain sensitization. So this is enhanced activity within the pain pathways. You have increased membrane excitability, increased synaptic efficacy, you have reduced inhibition, and so this is a big part of this reason why we experience chronic pain. And there's a manifestation of neuronal plasticity, so changes in the nervous system within the somatosensory pathways in response to that activity, inflammation, and neural injury. And we also have some descending pain modulating systems that can malfunction. So we're going to talk about pathways in the brain that come down. Actually, we have these endogenous pain reducing pathways in our body. And if they become malfunctioning, then you can end up having exaggerated pain. And so here's another example of something that happens in response to some nerve damage. You damage your nerve, and the microglia near the afferent nerve terminals in the dorsal horn are activated in response to this tissue damage. And they release all these various pro-inflammatory cytokines, like nitric oxide, prostaglandins, ATP, tumor necrosis factor, and all these things are released. And they end up, so there are within these microglia in the dorsal horn of the spinal cord have purinergic receptors located on them. And they end up releasing these chemicals, and then these chemicals in turn go back to cause increased release from that afferent nerve terminal. So the nerve was damaged, the nerve activated, released all this stuff, and now these things that are in the vicinity of the dorsal horn are all now going back and causing further release of neurotransmitter from the afferent nerve terminal. So again, exaggerating the amount of activity and increasing postsynaptic excitability. And other changes that occur are nerve sprouting. So fibers that were normally just from touch receptors now begin to synapse on dorsal horn neurons in the spinal cord that normally only received information from pain fibers. So now there's real true changes in the nervous system. And how we talked about that the C fibers release a combination of substance P and glutamate. Well, this exaggerated release of this substance and the excessive activation of N-methyl D-aspartate receptors in the dorsal horn on spinal neurons is a phenomenon called wind up. And again, you're winding up the system, and so you are increasing the activity within the nociceptive pathway, so you're getting greater and greater pain sensation. Chemicals that are released by nerve injury, including TNF and nerve growth factor, These are picked up by nerve terminals in the periphery, transported via TrkA receptors in the nerve terminal, goes into the dorsal root ganglia, and this is fascinating. They change gene expression in the dorsal horn neurons. So a neuron that previously did not contain contain chemicals that would mediate pain sensation now begin to mediate pain sensation. So nerve growth factor increases the production of substance P and can convert a non-nociceptive neuron, like a touch receptor or proprioceptive nerve, can now become a nociceptive neuron. So there's an actual phenotypic change in the dorsal root ganglia cells. And nerve growth factor influences the expression of a tetrodotoxin resistant sodium channel called NaV1.8, which are unique to nociceptive neurons in the dorsal root ganglion. So again, they can now be expressed in a neuron that was previously just a touch receptor neuron. And so a touch receptor neuron becomes a nociceptive neuron. And so now, as I said, we have pathways in our body that actually are designed to reduce the amount of pain we feel. And so there's a theory that was developed in 1965. It's quite old theory. It's called the gate control theory of pain. Whether or not this actually occurs, there are some people saying, nah, it really doesn't. But in many ways, it sort of explains some things we know about modulating pain. The concept of the gate control theory of pain is that so we activate a pain pathway, but the pain fibers, and they do their thing in the spinal cord, and they activate the spinal thalamic tract neuron. But in addition, if you now activate a touch receptor fiber, so these are larger afferent fibers, if you activate those fibers, they activate an interneuron that's an inhibitory interneuron that inhibits the release of transmitter from the pain fiber. And so this idea, think about it, if you cut your arm, for example, you rubbed against something and it got injured, it's not uncommon for you to rub the area around the injury. So what you're doing is, in a sense, you're activating those touch receptors in the area, and it helps to reduce the pain. And in fact, this idea behind the gate control theory of pain, though I say a lot of people say, no, this is not really a true pathway. There are some clinical therapies that are actually suggest that it is a pathway, and that is, you can reduce pain by transcutaneous electrical nerve stimulation of the dorsal column or peripheral nerve, and specifically targeting the larger afferent fibers. And so not the pain fibers themselves, but to activate the touch receptors and the dorsal horn and the dorsal column neurons that are involved in mediating touch. And so a clinical therapy called transcutaneous electrical nerve stimulation to reduce pain. But I'm also fascinated by the fact that we have endogenous opioids and pain modulating pathways. So I've got here on this diagram here some of the areas of the brain that are involved in modulating pain. So the periaqueductal gray is a site where opioids act, as are the nucleus raphe magnus. NRM is nucleus raphe magnus. LC is locus ceruleus. The periaqueductal gray provides input to both of these regions, the nucleus raphe magnus and locus ceruleus. These neurons project down to the spinal cord. Raphe neurons release serotonin, locus ceruleus neurons release norepinephrine. They act on a group of neurons in the spinal cord that contain an endogenous opioid, enkephalin. So these are enkephalinergic neurons. And activation of those interneurons, they're inhibitory to the sensory input coming in. So this is a way of activation of this of the periaqueductal gray, nucleus raphe magnus, locus ceruleus, down to the spinal cord, interrupts transmission right at the level of the input and the dorsifloran neurons. And so there's opioids can act right, endogenous opioids can act at various levels, including the spinal cord. And one of the fascinating things about the interaction between the ascending, the spinal thalamic tract pathway, and these descending pathways, it's a remarkable nervous system that we have. So up on the top is, so this is the neospinal thalamic tract. So this is the pain, the part of the pain pathway that goes right up to the primary somatosensory cortex, where we can say we can localize where the pain originated from. So, you know, if you stub your toe, if you stub your toe, it activates the primary somatosensory cortex controlling the toe. And so the neurons in the spinal cord that project on up to the thalamus and then to the cortex, these neurons emit collaterals into the brainstem, into the periaqueductal gray, on their way up to the cortex. These are the regions that in turn come right back down and feed down to then go and inhibit the activity in the spinal cord. So periaqueductal gray comes down and controls and ends up controlling, modulating the amount of information that goes up to the primary somatosensory cortex. So we have a built-in pathway, a link. So as we're activating a pain pathway, we're actually simultaneously activating the pathways that come back down to inhibit the pain. And so some ideas regarding this descending pain pathway is this term called diffuse noxious inhibitory control. And so you can reduce pain by noxious stimuli in other parts of the body. This is the idea behind acupuncture in many ways. And the thought is that activation of ascending spinal thalamic tract and descending pathways that release serotonin from the nucleus raphe magnus, or these opioids from the periaqueductal gray, coming down to inhibit the pain. So you have some pain coming in, and now you activate this, you activate a noxious stimuli in another part of the body that interacts with the part of the body that was originally the target of the pain. And then another endogenous pain modulating system is stress-induced analgesia. So you can reduce a response to innocuous stimulus during stress. And this is thought to be possibly connected with the release of endogenous cannabinoids. And so we think about, so somebody's out running a marathon and they're targeted, they want to win this, they win this race, and they're destined to finish the race. Along the way, something happens, they get cut along the way, they hit something and it cut their leg. They don't even experience pain when they get done running, they look down, oh my God, I had an injury. This is the idea that stress can induce analgesia. So while you're engaged in some activity, you end up not experiencing the pain because you're really destined to finish whatever it is that you were trying to do. And so now the rest of the time, I'm going to be talking about some drugs used to treat pain. So some of the most common drugs to treat pain are acetaminophen, and this is an analgesic, but not an anti-inflammatory. And non-steroidal anti-inflammatory drugs are NSAIDs. So you've got the cycloogenase inhibitors, salicylic acid, which is aspirin, that's rarely used today, and as an anti-inflammatory agent. And so a common thing is a sort of a combination of acetaminophen and codeine or oxycodone. So and then, of course, opioids are another drug that is commonly used to treat pain. There are a lot of research going on developing therapies that, in order to avoid the use of opioids, for example, it's not a good idea to need to be on opioids for a prolonged period of time. So when we think about someone who experiences chronic pain, then we want to be able to supply a treatment that would not have the ill effects of chronic use of opioids. And so it's trying to target specific pain receptors. And so some drugs that are used, for example, that we talk about TRPV1 receptors. So capsaicin is an activator of the TRPV1 receptors, those heat. So the hot peppers, the capsaicin, those are mediating, the hot peppers activate the TRPV1 receptors, the heat receptors. And there are actually capsaicin transdermal patches or creams have been applied to reduce pain. And the concept is they think that this is actually acting by, it activates the release of substance P in the nerves and then ends up depleting them. So initially you induce some pain to sort of then over the long term reduce pain. And then those NaV 1.8, the sodium V1.8 receptor channels that are specifically in nociceptive dorsal root ganglion neurons. And this is actually thought to be one of the targets that lidocaine may act by blocking this channel. And of course, lidocaine is a common local anesthetic or local analgesic. And then there are these voltage-gated calcium channels on those presynaptic nerve terminals of the dorsal horn. So remember we talked about how these nerve terminals were when the sensory neuron in the dorsal horn comes in and activates, that causes the release of all those chemicals from the microglia in the dorsal horn area and exaggerating the activity and keeps releasing more and more transmitter from the sensory afferent. So there's some drugs that are used that can block the sensation right in the dorsal horn. Ziconotide is an example of one of these. It was approved by the FDA in the US for use in the US for intrathecal analgesia in patients who have refractory chronic pain, and it's has found some success for that. And also the pain is thought here to be that pain is relieved because there's less glutamate, less substance P, less calcitonin gene-related peptide being released from those sensory fibers in the spinal cord, so reducing the amount of pain sensation. And there's interesting that anticonvulsant agents have been found to be a useful treatment for chronic and neuropathic pain. So when you think about it, what is pain? A lot of excitatory activity in the nervous system. What is epilepsy or convulsions? A lot of excitatory activity in the central nervous system. So it's not surprising that you would have a drug that could modulate both pain and convulsions. So a common one is gabapentin or pregabalin. So these are analogs of GABA, and they're prescribed to treat neuropathic and inflammatory pain, and they act on those voltage-gated calcium channels. And carbamazepine blocks voltage-gated sodium channels, and this is now the gold standard for treatment of trigeminal neuralgia. And then there are two drugs that are used to treat migraines, which early on we said was one of the most common types of, the headaches and the migraine headaches were common types of pain experienced globally. Valproic acid and topiramate are both examples of anticonvulsant drugs that are used to treat these pain from migraines. And the valproic acid acts on, is a blocker of voltage-gated sodium channels, and topiramate actually causes greater GABA transmission and also blocks those sodium channels. And we talked about the fact there's a relationship between depression and pain, and so perhaps it's also not surprising that some antidepressants have been found to be useful in the treatment of some types of pain. And the tricyclic antidepressants have been used to treat fibromyalgia, shingles, and diabetic neuropathy. And they're thought to act possibly by causing a release of an endogenous opioid system and activating that descending serotonin pathway from the nucleus raphe magnus. And there's also a lot of work going on now in terms of cannabinoid use for modulating pain. So there's actually some people that believe that this could be a superior system to opioids to reduce chronic pain. The cannabinoid 2 receptors activation leads to pain relief. They are not located, these receptors are actually not located on neurons, but on glia. But we talked about how microglia contribute to inflammatory pain. And so the idea of looking for a cannabinoid receptor agonist that is antinociceptive, but doesn't activate the cannabinoid 1 receptor, which are the ones that have the euphoric effect from cannabinoid. And so there's a lot of places that analgesics will act within the nervous system. And this picture here shows a variety of different places where, opioids act in a whole bunch of different places. And we have the sodium channel blockers and the NSAIDs and all these things. There's lots of places. So NSAIDs modulate the membrane depolarization in response to a peripheral stimulus. Sodium channel blockers decrease action potential conduction in the nociceptive fibers. Opioids, antidepressants, NSAIDs, and anticonvulsants all modulate transmission in the spinal cord by reducing the signal relayed from the periphery to the CNS. And opioids, as we said, modulate pain, the central perception of pain. And when we're using drugs to treat pain, it's actually very common to try to use more than a combination approach, as opposed to relying on a single drug to perhaps combine drugs to treat pain. This allows one to use lesser doses of each of the drugs, so less side effects. So the idea of there's so many different places that you can target pain perception. So giving drugs that act on different targets is a good idea. And so this is, a common approach to treating drug therapy is and not just for pain. We treat hypertension by multiple drugs. We treat lots of disease processes by using multiple drugs, because it's a way of reducing the amount of activity, the dose that you need to give, and so lesser side effects of each drug. And so I relied more on talking about treating pain, by reducing pain, by talking about using pharmacological therapies. But most clinical trials and guidelines for treating chronic pain recognize a very personalized approach to looking at an individual, treating their pain, and don't just rely on drugs, but psychotherapy, integrative treatments, and if necessary, some invasive procedures that might be useful in reducing pain. Obviously, we talk about the quality of life is why we need to treat pain, because we want to improve the quality of life in these individuals. And so various approaches. There's some new approaches that include some spinal cord stimulation and deep brain stimulation. There's a lot of work being done on treating pain and using non-pharmacological therapies. And that's it. All right. Do we have some questions?
Okay, thank you, Prof. Barman, for that wonderful talk. And bringing us up to speed. Thank you. There's a lot of new information there for us. Now, thank you. So we will now have the Q&A session. So, ladies and gentlemen out there, attendees, if you have any questions, please type them in the chat box, or you can raise your hand and to speak to Prof. Barman personally. Are there any questions?
If you have any questions, you can actually email me, and I will try to, if you want some resources or some more information. My email address is, let me put my email in the chat. I guess I'll do it as a type and answer here. I'm going to put my email address. It's very easy. And feel free to contact me if you have any questions. Did it go there or not? Let's see. Maybe here. Let's see.
Maybe at the end of this webinar, we can put the, okay, I can see the.
Yeah. I did it wrong. I responded to a question. I'm not used to the question and answer part. So, welcome to reach out to me if you have any questions. Maybe someday I can come to Malaysia and give a talk.
Oh, you'll be very welcome. Yeah. I have a question, so-called question. Actually, I was very surprised to learn that Malaysians are very, very tolerant of pain.
That's what that article said.
It's actually way below the world average. You know, the percentages are really way below the world average. So what about the other communities in Asia? Are they showing similar tolerance to pain?
No, so it was actually, it was remarkably different. It was remarkably, I mean, Malaysia sort of stood out as being unique in having a very low number of people expressing chronic pain. So it has to be that they're just more tolerant of it.
Oh, maybe that
you're hard souls, you really you persevere so that you don't let it get you down.
Could it be a different understanding of what chronic pain is?
And it could very well be that it could, and so the definition of chronic pain was like experience it over, I forget what the exact time frame was, but you had to have pain for X amount of time, and and so it could just be something simply of the understanding of pain in that way, and but when you think about it, again, this whole idea of pain, it's so subjective of how you define pain, because you could experience something and you just get so used to it. You don't even think about it as being pain. You go beyond it. I always say, I think I have a pretty high tolerance for pain. I don't like to take drugs. So, and I think part of it is maybe that it's just a matter of, why it is so much lower in Malaysia, and the percent of people that experience chronic pain, 7%, where I think in the United States, I think the expression of chronic pain is, I think I remember numbers of like 30% or something like that. So, I mean, really considerably different. 7 to 30 is a big difference. It's only maybe 20 in the United States, something like that. Whatever it is, it's still a lot more than 7%.
So your figures are actually very, very different. Yeah. But at the same time, I also saw your data showing that there's a very high usage of strong opioids in Malaysia.
So of the people that experience chronic pain, that they do, right. But, and now that study was ended in 2014. And I don't know whether it's the same way in Malaysia. In the United States, there's been a real attempt to try to reduce the number of people that are given prescriptions for opioids. So it used to be when I would go to I've had to have teeth pulled. I've had teeth implants put in too. And so when I would go to get a prescription to have a tooth pulled, and they would give me a prescription for an opioid. They'd give me Vicodin, a prescription for Vicodin. I would never bother to take it because I could tolerate it. The pain it would go away. I was fine within a little bit. And so, but now they absolutely would not consider, a dentist would not consider giving a patient Vicodin for a tooth being pulled. They give you Motrin. They give you an NSAID. Totally different. So there's been a big change in the United States in the number of prescription. Obviously, illicit use of drugs is high in the United States. I mean, it's, obviously lots of parts of the world have got a problem with drug substance use disorder. And in fact, next week I give a presentation on substance use disorders for medical students. And, it's a terrible situation.
Yes, I was going to ask about this fentanyl, severe fentanyl addiction in the US. Fentanyl.
I missed that.
Oh, yeah, there is a very severe fentanyl addiction in the US right now. Fentanyl? Fentanyl? Yes, fentanyl.
Yeah. And that's a dangerous, dangerous drugs.
Yeah. Okay.
But at the same time, if somebody has surgery, then in the hospital setting, having an opioid drug under guidance of a clinician is actually one of the best therapies for pain. Like I had to have a spinal cord surgery in 1992, and I was put on a self-administering morphine machine, and I didn't give myself anything the night of and the doctor came in and said, "Give yourself some, you deserve it." I said, "Well, as long as I don't move, I don't feel any pain." and so, but this is a way of if you treat it and you treat it only until you're treating it and you only have it until your pain is reduced, and you reduce it as time goes on. I need less morphine today than I did yesterday, and I take less then you're not going to get addicted to it. So you're under a controlled therapy. So narcotic drugs have a very valid use for surgery, for post-surgical pain, but not for chronic pain.
Hi, Prof. Bumans. We do have some questions coming in.
Okay.
We have one from anonymous attendees. For anticonvulsant drugs that are used for neuropathic pain, for example, pregabalin, in terms of physiological mechanism, how do the long-term use of this drug cause tolerance that leads to a possible need to increase the dosage of the drugs to achieve the same pain relief?
That's a very good question, and I think that's I don't know enough about the use of these drugs for that purpose. I know they're prescribed, and I know they're very functional. So my nephew, his girlfriend, has been suffering from migraines after she had COVID, and so she's been prescribed the topiramate, which is one of the ones for the migraine headaches. And she doesn't want to take, because she's afraid of those kinds of things of needing to use too much of it. But they said we'd start you on a really, really low dose. And I think, so when we think about you would never get to the dose that was used to treat epilepsy. So they're used at lower doses, but it's a very good question. More, whether or not, how easy it is to develop tolerance to those drugs. I don't think that those drugs are ones that have necessarily a high tolerance development from them. So, but I'm not positive about that. So I can't say for sure, but I don't think that they are particularly susceptible to tolerance. Things like, whereas like an opioid drug, definitely tolerance develops for sure. It's a natural thing with that, but good question.
Thank you. We have another question from Dr. Chitra Devi. Does menstrual cramp pain share similar nociceptive pathway as the cardiac arrest?
Okay, say that again.
Does menstrual cramp pain share similar nociceptive pathway as the cardiac arrest?
Is cardiac arrest? I'm not sure how to answer that. I don't know that. Yeah.
I don't remember pain of cardiac arrest.
Sorry, Prof. Lam?
In cardiac arrest, the patients will feel very intense pain. I think probably Dr. Chitra is asking about that, whether they share the same pathways.
So the concept of, there's a phenomenon called referred pain, where parts of, so if that's what you're thinking about, are pain, from different areas. So, like if you have a heart attack, if you have heart pain, you don't say, oh, my heart hurts. You say my shoulder hurts or my back hurts, so there's a phenomenon called referred pain. And it's because the same group of neurons in the spinal cord are activated. So that it's from that area, from the somatic structures, then the visceral structures. So visceral pain is an example of referred pain, because, and so the concept is that the same dorsal horn neurons then connect up to the brain, are activated by visceral organs and by somatic structures. But throughout your life, your body was used to being touched or hurt in the somatic structure and not from the visceral structures, so that you don't say, oh, I have a heart pain. No, I have a shoulder pain or a back pain, because the sensory fibers are from the same areas that are for the heart.
Okay, thanks, Prof. Barman. Another question from Dr. Kumar. Thank you, Prof. Barman. Can you confirm if the acute pain sensation does not involve any tissue injury, while the inflammation pain does?
The acute pain does have tissue, can be tissue damage, or they also say, or threat of tissue damage. So I think the idea is that the threat of tissue damage, so not enough, the injury wasn't severe enough to cause tissue damage, but you still feel a basic sensation of pain because the receptors were activated, but not long-term response. So the definition of pain being tissue damage or threat of tissue damage. It's always confusing to me, because I would think it means tissue damage. Something happened to be damaged to cause you to feel pain, but that's the definition from the International Society of Pain, says it's or threat of tissue damage.
All right, I have a question actually.
Sure.
I do develop migraine, especially when I observe I have a stomach bloated. Gas. If I miss the timing of eating, and then I start to have gases in my stomach, then I start to have migraine. And it's very interesting when I observe myself. Is every time when I felt an hollow sound on the right side of my stomach, and I have my migraine on my left side. So do you think that the theory of gut brain axis relate to this?
That's a very interesting phenomenon. I mean, it could very well be that and the whole idea, so migraine headaches are really, so many different formats of a migraine headache, and so what exactly is happening? Because is it really pain activation, or is it swelling of vessels that's causing it, or what? So that's a fascinating that you could actually sense it. You get the headache on the opposite side of what the pain pathways go up, cross over. So it could very well be.
Yeah, I mean, I guess one thing is that I don't, I don't, go to the hospital to see doctors to treat the migraine, because I know that the source has come from my stomach, and every time I relieve the air, and the migraine just goes away. So
that's interesting.
So, it's kind of interesting. I also do not know how to explain it as a physiologist. Thank you, Prof. Barman. Any more questions from